Ladies and gentlemen, that's how the fibers move from the eye right up to the brain and the appreciation of the vision. Now let's look at the visual field defects. When there is a defect, when we say visual field defects, there will be an area a patient can't see. We want to know where is the actual lesion in the visual pathway. What we did is a visual pathway from the eye to the optic nerve to the until you reach the cortex, visual cortex. Now you have a patient who has a visual field defect. They can't see maybe this part of the field. The idea is to try and localize where is the lesion for this type of visual field. Visual field's definition is an island of vision in a sea of blindness. Peak of the island represents the point of highest vision or acuity, and that's the fovea. Bottomless pit, the optic disc. Because at the optic disc, light shining on the optic disc is not appreciated. So it's a blind spot. Like you are looking into a bottomless pit. You can't see the bottom. That's the you know. Visual field, we'll look at the visual field testing, the stimulus, how to test the island of vision, and various levels requires targets that vary in size, in intensity, and in color. I'm all right, Mommy. How are you? Shimpa, shimpa. Field testing methods. One, kinetic. Kinetic comes with energy, isn't it? It means there is some movement of some sort. So this is mapping the contours of the island at different levels, resulting in one isopter for each level tested. Static method, they use the vertical contours of the island along selected meridians. Visual fields divided into central vision, 30 degrees radius from the center. Peripheral vision beyond 30 degrees radius from the center. When you look at the central vision, that's the 30 degrees from the center or from the macula. 30 degrees is referred to as the central vision. Beyond that is the peripheral field. Okay. Central visual field is examined by the following methods: the Amsler grid, the tangent screen, Bohr perimeter, and the confrontation technique. Confrontation, the easiest, where you have no instruments. You are now bringing this object into the visual field. From there, you can't see it. You'll be looking there, isn't it? Immediately it comes in the vision, I will say, I've seen it. So, although I'm looking straight, I can see this. So you remark, my vision is up to there. Even there, once I close this, I can't see it. But as soon as it comes in the, so I've got this kind of vision, you know. Although the best way to learn this is actually practice. I hope we've got these in our clinic. We should have in Levy Mwanawasa, these instruments, the visual field machines. Everyone who is working there, whether clinic officer, nurse, or whatever, it's not for the clinic officer, it's not for the doctor, it's not for anyone particular, it's for everyone to know how to do it. These are some of the things you'll be examined on for practicals. It cannot be for the doctor alone. You want to be everywhere. It cannot be for the nurse alone, the clinical officer alone. Everyone should be able to do these tests. So that there's nothing, initiative, our doctor, no, we don't want that type of attitude. Anyone who is there can do. Anyone who is in the department can be taught, apart from the cleaners, those, it's not their job to do this. You can't, because apart from the fact that they can do it, but you can't hold them accountable if they mess up issues. It's not part of their job description. But a nurse, a clinical officer, it's part of his job prescription or her job prescription. So those whose job prescription is clinical, dealing with patients, should be able to do this. They can be taught to do this. That's the approach which I favor myself. Not having one specifically is planted there. No, Mr. The one who does it hasn't yet come. No, can't work like that. What is it? It's just a clinical officer. It means everyone who is a clinical officer can do the job. Everyone who is a doctor can do a job. It's a question of teaching and putting them there for a week. Today we'll be learning this. If they work there for 1 month, they will know the job. Then they can rotate to another section. That way you have a group which can do anything. I think that's the way we should be going. Amsler agreed useful in detecting subtle central and paracentral scotomas. Difficult ones. When he held at 1/3 of a meter, 1/3 of a meter is about 33 centimeters, isn't it? Yes, 100 centimeters is a meter, my friend. you can do that. Tangent screen, good for examining central fields, easier to pick up central defects, as scotomas will be 3 times as large as 1 meter at 1 meter in a tangent screen. Not useful for testing beyond 30 degrees because of diminishing stimulus from the center. As you go, the stimulus gets diminished. You are looking there, but there you start losing. You can't appreciate clearly. But the bottom line is what I'm saying. Every member of staff to be taught how to do it. Within a month, you can teach them. Within a month, they will be doing the fields. This is what you have done. Okay, let's go and counter check. You counter check, everything is okay. It means someone is picking up. And that way, clearing of patients in your department will be faster. Everyone will be knowing what exactly you're talking about. If a special defect is noted, people will appreciate that this is how this thing happens. They can, in fact, at some stage, the same people are saying, no, these are just necessary. They will be making a diagnosis. The doctor said, if it's like this is the answer. And that's what we want. That's what we want in modern medicine. It's not about Dr. Mumba knowing everything. Peripheral visual field requires testing with a ball perimeter. There are those special ball perimeters. Automated perimetry able to examine central 60 degrees field. Manual perimetry tests entire visual field, helpful in detecting ring scotomas, e.g. glaucoma, nasal step, or retinitis pigmentosa. Temporal crescent due to occipital lobe lesions. I think what I can say, emphasize, is that these things, testing, should not be no. If you come to my department, there's nothing like that. You can change, not at Mombela Kurifi. Because that way it gives you a chance to learn more, and it gives other people a chance to learn, and it makes the department more jacked up. easier to manage patients. Everyone who is there, they've got a good idea about it. That's the only way you can run some of these things. Not, abachitafe central vision tabalipo leo. Not in my department. Nerve fiber pattern of the normal retina. I think we looked at this. We looked at this. Papillomacular bundle fiber defects. This is called a blind spot. What is this? Blind spot is what?
Optic disc.
Yes, the blind spot is the optic disc. So if you are going to have this, it means between the macula and the blind, the optic disc, those fibers which come directly like that. You see? Because the fovea is there. This is where the fovea is supposed to be. So if all this is blind, the fovea is there, it means the fibers from the fovea are also affected, going into the disc. This is the optic disc. The macula is there, but the defect is away from the macula there. Okay. What is this? We were saying the macular fibers. If this is the macula, these fibers, they normally go up to enter there. These fibers here don't enter directly there. Remember? These fibers go up, go down to enter like that. It's only from the macula there which go directly like that. But it also depends what is the lesion, what is the cause of the defect here. Like when you look to the sun, damage of the fovea, you find this is all blind. So this is central vision. Okay. Aquate nerve fibers. Which one? What are these? Aquate. What is what? Aquate is like that. Aquate nerve fibers. Nerve fiber bundle. Okay. Fibers from the retina temporal to the fovea. You've got the fovea here, temporal there. These fibers have to go above the macular papillary bundle. So they are curved above to enter the optic disc. That's what they mean by aquate. They don't go directly in. Only macular fibers go directly. Those that are further there, they have to go around like that, go around like that, go around like that to enter. Those are the aquate fiber bundles. Well, if it is the optic disc, from the other side, they just enter. Nasal side, this is, no, this is the nasal, this is the temporal. Because the eye is like that. There are two eyes like that in the head. So when you look there, this is the nasal part, this is the, so you have your vision like that. Fibers from here enter directly. Fibers from here to enter the disc there, they have to go up like that. These are the arcuate vessels. Okay. From here, they go directly like that. They don't have to go over, and even here, direct in, but from here, they have to go like that into the disc. Okay, they are entering into the disc. So fibers from the retina temporal to the fovea. This is the fovea, temporal to the fovea. Nasal is in the center. Fibers from the retina temporal to the fovea enter the superior and inferior pores of the disc. If this is the disc, this is the macula. Fibers temporal don't go directly. They have to bypass upward and downward to enter these parts of the disc. Only fibers from here will go in. In fact, from there, once the things have gone in, they go in straight. From there, okay. Superior and inferior pores of the disc. The gerum arcuate scotoma, usually at 15 degrees. Defect in the proximal portion of the nerve fiber bundle, causing a comma-shaped extension of the. These you need to see them pictures to appreciate. I hope I can come with some. Defect in the distal portion of the nerve fiber bundle, nasal step. Nasal step where you have there, like that. There's a step. Note, nerve fiber bundle defects originate from the blind spot, not from the point of fixation. Machaiwe ndeisa nishire kusanga utombera pamwana mutufola fye wino oh nakulalibisha ma you know it changes. Continue. Okay. So these are nerve fiber bundles. Then the next one is 10. Okay. Okay. This one. Yeah, it's originating temporal to the macula. This is the macular area. So it's going above. Those are the arcuate nerve fibers. Ngayachita originate from the center. It means there will be blind spot. When there is a macula itself involved, then it means this is the blind spot. You can't see it. A patient may see a bit on the sides, but centrally, when they look directly on the object, they can't see anything. It's all gone. But in this case, this patient will see central vision is there, except there is a reduction depending on where this arcuate scotoma is. If it's, say, a bit far out there, you're almost done, like a normal person. But as soon as it comes close to the macula, it becomes a problem. It starts like that, and then you end up like that. Okay. Next one is Okay, let's go to this one. Where is the visual field defect? This one. This is the left eye. This is the left eye, this is the right eye. Now, where do you look? So, where do you look? Yes, exactly. That's the point I wanted to hear. But picture it is superior defect. The defect on the retina is the superior retina, giving you an inferior visual field defect. If this defect was on the inferior side, or on the actual retina, the field will show superiorly, because the light falls on that. So these things, you must know where the field is and the expected, because they'll say, here's the visual field. Where are you going to look in the retina? Don't say the inferior field, you will not see nothing, you will see nothing. Supposed to be inferior field, superior, it could be affected like that. Nazo, it means in temporal. Temporal, it change like that. When you are looking at the actual patient and the field, you have to pay so. Well, some examiners, where specifically, you say, where are you going to look for? I'm going to inferior to inferior rating. Okay. Because you will not see anything there. If this is inferior, it means the defect is on the superior part. If it is inferior, the field, the defect is in the inferior part. If it's temporal, the defect is nasal. If it's nasal, the defect is temporal. Like that. Only central vision will always be central, because takwa central na imbi yako for the knowledge. Just my mama. Therefore, my child, Tamagarasia. Ushita kwa ni yaba bene babanga.
Nyaba bene, pero no, kwa hali kwa doctor hali nso.
Bali chipaba.
By 4 or 6 foot.
Ndefo kushita lenje bati 6 foot.
6 foot.
Ati na frame fyonse.
Frame fyonse. Kwati yo ine mufere mele masendele yoko.
Kwa.
Yali kosa.
Okay, kanshinga na lashita kanshinga ni na frame ya nyowani. Okay. Maironka muletera. Aya, kaparo. Alibanza. Okay, na alafu mtumena alikwata phone yako. Maironga kuletera 6 foot ndepa maglasi yako. Eronka kuri abaiche weekend mofya ma bifoku. You understand there, huh? I hope the other students are they are with us.
They are listening.
Okay. This is very, very important in my short, practicals. They will show you this. What is it? Okay, no, this is the chance. You talk nicely, isn't it? Okay. Can you have a look? Immediately we start looking into the inferior part of the retina. Now we see a point. By interpreting wrongly this. If the field is inferiorly, it means the pathology is superior. It actually reverse like that. Okay, Key points in patients with quadrantic field defects. Does the defect go to fixation or to the blind spot? Okay? Let's see. Which is the blind spot? The blind spot is where the fibers come out of the eyeball. The optic disc is the blind spot. There are no cells for sensation of light there. That's why it's called the blind spot. Well, the actual fovea is a point, it's not a blind spot, a phobia. That's why there is a tip-top vision. So when there is a visual field defect, does it go to the blind spot or does it go to fixation? Fixation is the macula or the phobia. So that's why you fixate. Okay. Key points in patients with does the defect go to fixation or to the blind spot? Very, very important. Once you sort out that defect going to the blind spot, retina, nerve fiber, or optic nerve before reaching the chiasm. For the defect going to the blind spot, it means there is a retinal nerve fiber or optic nerve before reaching chiasm. Defect going to fixation, lesion in chiasma and further posterior. Where is the blind? Where is the lesion? This is how we work it out. Decrease the visual field, decrease the visual acuity. Light brightness comparison. Eye with optic neuropathy will see the light as less bright. If there is an optic neuropathy, optic nerve infection, fibers of the optic nerve affected by some pathology of some kind, it means in that eye, they may be seeing, but eye with optic neuropathy will see the light as less bright because the fibers there are affected. It's the optic nerve affected. If they are seeing same, there is no optic neuropathy. Okay. Color perception comparison. Use color plates or mediatricil, or the midriasil bottle cap. Color cap. So, ile mwana kashani, you close this. Kama na ngo kuwa kwa. Nimesa kwa ili so ile mwana katakali sana bright. Thank you. It means na ipata optic neuritis. Color perception comparison. Optic neuropathy, light brightness comparison. Eye with optic neuropathy will see the light as less because it has got optic neuritis. Inflammation. Just by doing like that. Where does this look brighter? When I see with this one, oh, good. On the other side, there's optic neuritis. Okay. Then eye with optic neuropathy will have diminished color perception as well. Okay. Eye with optic neuropathy, diminished color perception. RAPD. What is RAPD? This is something you're going to be finding in books and books. Relative afferent pupillary defect. What is called the swinging flash test. The other side is a problem. Then ophthalmoscopic evidence of optic disc abnormality, e.g. pallor, capping and drusen. Pallor looks more whiter than the other side, you know. Then capping, more capped. Normally, a capped disc also looks whiter than the other side. A capped disc means glaucoma is hammering there. The vision will be less there than in an uncapped disc. Those are the things we look at. Quadrantic field defects. Quadrantic field defects, it's a quadrant, one quarter. But they are going where? This one is going to fixation. Okay, this is the center. This one hasn't reached there. This one is going round. Where is trying to read you to know how to do which tiny large. Again, hold up. There you go. The key question in a patient with a quadrantic visual field defect, does the field defect go to fixation or to the blind spot? If it goes, does the visual field, quadrantic visual field, does it go to fixation or go to blind spot? If it goes to the blind spot, it's an optic nerve lesion. For example, this one is going to the blind spot in the center. No. Blind spot need any point of fixation.
So this is a blind spot.
This is a blind spot. This one is coming to the center. Optic nerve, retrochiasma. Let's go up. The whole thing. I don't know what you think. Okay. The quick question in a patient with a quadrantic visual field, does the field defect go to fixation? If it goes to fixation, it's retrochiasma. Okay. Or to the blind spot, optic nerve lesion. Blind spot is not. Where is fixation? But when you say to blind spot, is the disc upper center. A blind spot. Apa ile ya ku fixation the fixation point. This is blind spot. This is fixation. Are we clear? Why is this a blind spot? Because this is this is a blind spot.
It's the optic disc.
Yes, it's the optic disc. It's the optic disc. Yeah? But this is the macula. Macula is off from the optic disc. So if the lesion is going to the macula, then you follow this. It's going to fixation because we fixate with the macula. Yeah. So a quadrantic lesion, does the field go to fixation, a retrochiasma lesion, or to the blind spot, optic nerve lesion? Blind spot is optic nerve lesion. This one is optic nerve. That's how it goes. Next one.
There's someone who was
Playing.
who painted this. So unless them they erase. I don't know if they wanted clarity or something.
Optic chiasma, or the same thing. Optic chiasma and visual field defects, important points on course of fibers, bundles in chiasma. Temporal fibers remain uncrossed. Yeah. It's the medial fibers which cross, you know. Inferior nasal retinal fibers crossing the chiasma. Remember in the picture natural sometime back a picture natural show. Junctional scotoma. A central scotoma in one eye with a superior temporal field. in the fellow eye indicate a lesion at the junction of the optic nerve. Left eye in this case, and the chiasma junction scotoma. These fibers, you know that the medial ones cross. The ones on the temporal side, they pass through. So optic tract is with crossed fibers and uncrossed fibers. Optic tract lateral geniculate bodies defects. All retrochiasmal lesions result in a contralateral homonymous myopia. What is contralateral? If the lesion is this side, if the lesion on the optic tract is here, the field is there, the defect is there, contralateral. If it's here and the field is here, it's ipsilateral on the same side, contralateral on the opposite side. Left congruous homonymous myopia. Both sides, in the left and in the right. Get outlook on your phone for free. I don't know whatever outlook. What is outlook?
It's an application.
For what?
It's more like email
Like email.
or Yahoo, yeah. Email.
Too many applications will just confuse you.
Are we here?
Next slide. Next slide. Hey, the touch that for you.
This one.
Yeah. Homonymous myopia, it means both the left side. You know, they're homonymous myopia. And the visual field look almost the same. But they're in two different eyes. This is the left, this is the right. So this, where is the lesion? Homonymous, congruous. Where is the field? Where is this? Okay. I think the explanation is incongruous myopia, bilateral retinal fiber day atrophy, optic atrophy, abnormalities. RAPD on the side opposite the lesion, eye with temporal field. RAPD on the side opposite the lesion, the eye with the temporal field defect. Let's see. Which one has the temporal field defect? See this eye, left eye. Left eye congruous myopia. Because the in field defect, is temporal of the left, is nasal of the right. Well, this is what the patient is seeing. So if it is there, that's what is explaining apart. The one on the temporal side. Come over. Says incongruous myopia, bilateral retinal fiber atrophy and optic atrophy. RAPD on the side opposite the lesion, RAPD on the side opposite the lesion, which is the eye with the temporal field loss. So the eye with the temporal field loss is this, but this one will have RAPD. Right eye. Okay. In 28,
It's
7 slides. Okay. Lateral geniculate body field defects. Two types of defects. Incongruous homonymous and relatively congruous homonymous horizontal sectoranopia. Associate, it's a sector, it's not a complete hem. When the sectoranopia is a sector, or like a quarter. Sectoranopia. Associated with optic atrophy may be due to vascular infection or a portion of the lateral geniculate body. Okay. This is incongruous left hemanopia. Incongruous homonymous hemanopia, bilateral retinal fiber layer atrophy and optic atrophy, pupillary abnormalities, RAPD on the side opposite the lesion, eye with the temporal field defect. Like RAPD here will be in this one, because this eye has a temporal field defect. This eye has a temporal field defect. The RAPD. So this is the criteria which you must know to work out which one is at fault. Criteria for optic tract syndrome. You see, they are congruous. Deaf, they are same picture, not incongruous. These are congruous. You can see how same pattern, sort of.
Oh.
This is 20. We're going backward, eh? Temporal Mayer's loop. Tuachavesa? Iya kongapo? Oh, like that, eh?
No, here.
We are now upper. 8. Superior inferior separation of fibers in the temporal lobe. Inferior fibers, which is the ipsilateral inferior temporal fibers, and the contralateral, which are inferior nasal. Course anterior from the lateral geniculate body into the temporal lobe, forming Mayer's loop. Note, anterior temporal lobe lesions tend to produce mid-peripheral and peripheral contralateral homonymous hemanopia, half fields. Quadrantinopia, quarter field. Okay, hemanopia is half, quadrantinopia is quarter, which they call pie in the sky. Sometimes very superiorly, they are quadrant. They call it pie in the sky defect. It's a quadrantinopia. And the pie in the sky defect is anterior temporal lobe lesions. Temporal lobe lesion. Temporal lobe lesions. Pie in the sky. superior and inferior separation of fibers in the parietal lobe. These are good to study, but they get stuck in the head with a patient or with a tutorial like that, you know. Just going through, no, going through is not good enough. You find there's still something missing. I prefer such a lesson. We go through slowly. The patience, better. Because students will appreciate that nyapa tulinomba. But sometimes it's not possible to have all the patients available for demonstration. Visual cortex field defects. In the visual cortex, macular representation is located on the tips of the occipital lobes. Right? That's the tip. And lesions affecting the tip of the occipital lobe tends to produce central homonymous hemanoma. Stuff. Map. Tip of the hospital. Somewhere. Macular sparing in visual field defects. The macular area of visual cortex is a watershed area with respect to blood supply. Macular visual cortex is supplied by the terminal branches of the posterior and the middle cerebral arteries. If there is obstruction of flow through the posterior cerebral artery, ipsilateral macular visual cortex may be spared because of blood supply provided by the terminal branches of the middle cerebral artery. The supply is two. So if one is blocked, the supply from the other one can be intact and spare the area. In order to qualify as macular sparing, at least 5 degrees of the macular field must be spared in both eyes. Bilateral homonymous hemanopia with macular sparing produce constricted visual field with normal fundi. Normal picture. It's just the macula which is affected. They're also putting those on your phone. Oh.
I was removing them.
Okay.
Like they're failing to delete them.
Or to delete it. What for me at your normal? Thank you.
Oh, someone is able to draw on their phone.
Okay.
Maybe they want to highlight something.
The question I want to ask is, how is it going?
They will respond.
No, not they will respond.
On
You on your own. Half, you can see. Hospital lesion, macular sparing. Half, but you can see the central is spared. The macula ngaba involved, it will come straight like that. Constricted visual field differential diagnosis is stereo and malingering. Anyway, stereo and malingering, normally things don't match through from what the patient is saying. You can see at glaucoma, optic disc drusen, post-papilledema optic atrophy, retinitis pigmentosa. Note, to rule out stereo and malingering, do visual fields at 1 meter and 2 meters on tangent screen. No tunnel vision should be seen. ngatapali tunnel vision enomo nomba ngavika pa 2 meters ati kuli tunnel vision ifyakufi. Waimona the point. This is 1 meter, this is 2 meters. So ngolemona tapafwira okuba tunnel vision. The more you go, the bigger the area you see. When it comes nearer, the smaller the area you see. Ngawaya so kaidi ile chita expand second. So ngakwaba tunnel vision up to 3-4 meters ni shia kufika hivi. Tafwira okuba tunnel vision. Straight kumwikata fya bufifya lewe. Yep. Sorry, I go back.
Here we are.
Oh, this will come down there. Congruity, homonymous manopia field defects are said to be congruous, so exactly the same. If defect is not complete, it does not occupy the entire half of the field. Defects extended to the same angular meridian in both eyes, not complete homonymous manopia, cannot be categorized by congruity because it is complete. Optic tract lesions tend to produce markedly incongruous defects. The more congruous a homonymous manopia is, the nearer the lesion will be to the occipital cortex.
Okay, there's a question. Someone is not clear. They ask and say, what is tunnel vision?
Okay. Tunnel vision is the way the word is a tunnel. It means you can't see outside that area. A tunnel vision. You can't see. Your visual field is tunnel-like. Well, there's still some people listening in. It's good. Good. Stopping share or going?
No.
Nah, yeah.
We are the ones to.
Oh. Retinitis pigmentosa. Those are the things which normally give tunnel vision. Central vision lasts to go. Okukonsoku, they are damaged. Go around. What is this? When is 27? 27. 27. Transaction successful. Okay, 2020 part. Yeah, push that to time. No problem. Sungwa, kutuma messages to phone put konka wino sana. Okay, my dear. For meaning ya congruity, congruous. If defect is not complete, does not occupy the entire half of the field, defects extend to the same angular meridian in both eyes. That's congruous. They appear same, you know. Optic tract lesions tend to produce markedly incongruous. The more congruous a homonymous myopia is, the nearer the lesion will be to the occipital cortex. Occipital cortex lesions are the ones which give congruous lesions. Eh? Oh, the same one. Congruous left, one. Exactly. In both eyes, they are exactly the same. At which angle below that, below same. Uku is straight, no straight. That's what I mean. Equal shape, sort of one size. Congruous. Left, homonymous, because they are both left-sided. If could have a right homonymous, they are on the right side both. But the congruity is the shape is exactly the same. To the same extent. This is 135, nay, 135. Same. So this is what is meant by congruous. These occipital, congruous lesions, occipital cortex, not macular. Macular kaina ishara. Okay. Go to the next one. Temporal crescents. Temporal crescents. Yeah, that's what in 37 next. In each eye, a temporal crescent of visual field for which there is no corresponding visual points in the other eye exists. Temporal crescent of field perceived by a nasal crescent of retina is represented in the contralateral visual cortex in the most anterior portion of the mesial surface of the occipital lobe. The temporal field. No. Tell us it. Picture. That left. A myopia, congruous. Occipital lesion, macular sparing. Where is the macula? Center. This center of the vision is macula. So when they say macula sparing, don't point at that one. It's this which is spared. This is the fovea.
No, this one.
Fovea is the center of the macula. So it can't be outside.
It's within there.
This might be no, it can't, it's not. Because this is the macula. Fovea is the center there. So there. Yeah, I think, look, this is, you say this what? This one? No, fovea is there.
Then this could be
part of the optic disc. Fovea nyap. Central vision. Fovea and central region. Hospital region, macula. Fovea is the center of macula. Okay.
So we're through with sensory and visual defects.
Are the people still there?
Yes, we are having 9.
Ngabonse, bye.
It's
Ishita ishito.
12:48.
Naka. Wanaka.
We open it for questions.
Yeah, okay. Open for questions. The sensory visual system
And visual defects.
and visual defects. Okay. Okay.
Questions are welcome.
Let's hear the questions. No. We are here. All for Mrs. Nguni. Oh?
Why did we leave them?
Oh.
We leave them there, people come. Weekend, the family went. So we have blocked them.
Eventually, I will be taking home. This is a village.
Well, these people are not very question.
And people get tired, especially the whole day.
What's the question?
Yes,
Seems they're quiet. They don't want to talk.
they're scared. Well, they've heard. The lecturer is happy when people, students have heard everything. So we proceed. Yes, sir. Yes, sir. My question guys, question kafika mama. That was somebody. I think if male umpa kwa pa. If mo fine. I think akatwacha ya sensory visual system.
So we're remaining with the
Sensory visual system.
ocular motor.
Poses. Ocular motor poses. Okay. Visual field defects. But
We've done both
sensory and visual field. Yeah. The idea of visual field defects is when you see this, where is the site? Is the commonest question. So you should appreciate how the fields are done, how they are made, how they come out. Like a particular central.